Hi, everyone.
Hello.
How is everybody today? Welcome to the PMP Pals Hope Zoom call. And we're all excited to see Dr. Mageed's presentation today.
Hello from the Sisneys in Kansas City.
Hello.
Linda and Brian, welcome. We're so glad you could join us.
We're here.
Yeah, so glad. So very, very long time patient and caregiver.
It has been a long time.
One of the greatest parts for me about this weekly Hope Zoom call that we've been doing since the pandemic started is having longtime patients who were inspirational to me when I was going through my treatment show up now. And it's just amazing to see folks still thriving after all these years. We are so happy to see everybody. I say it every week. I'll say it today. This is the highlight of my week, spending time with each of you. So thank you for being here. We are super excited about our presentation today with Dr. Hisham Abdel Mageed from Cairo, Egypt. He will be sharing the updates from his practice today. And we always love our physician presentations. So I know you're going to love it. As we start to get started, I will go ahead and introduce myself and the board, the people that support us every week. And so welcome again. I'm Chris Piekarski. I'm the president of PMP Pals, and I'm a 16-year survivor of appendix cancer. Adele, would you like to say hello to everybody?
Sure, Adele Jason. I'm the vice president of our board, and I'm a 9.5-year survivor.
Hi, everybody. Charmaine in Austin, Texas. I'm on the board also, and I was diagnosed 23 years ago and had RS surgery and Hipec 12 years ago, and am no evidence of disease still.
That's fantastic. And now I also see James. James, would you like to say hi to everybody?
Hi, everybody. James Caldwell from Northern Ireland. I'm soon to be a 7-year survivor from a high-grade appendix cancer, and I'm one of the admins on the Facebook group.
Thank you, James. And if you're not familiar, the PMP Appendix Cancer Facebook support group is a group that we endorse. There's over 4,500 patients and caregivers on that site now. And so it's a good place to get some information and support. So we do encourage you to go there if you're interested. And James, we thank you for your tireless work there as administrator. Is there anyone else? I think
Connie is just joining.
Connie is just
she is here.
Bringing up the
Yeah.
rear. How are you?
Good. I'm fine. Good morning. I wasn't sure if I was going to make it.
Oh.
I'm happy to see everybody. This is going to be an exciting presentation.
Glad you're here. Thanks for making it. It's good to see you.
Yeah, you too.
Good. Well, I will, before I introduce Dr. Mageed, I'm going to take just a moment just to show folks how this works, because I see a lot of new faces today. And I will share my screen and once again welcome you to the Hope Zoom call. PMP Pals is the world's oldest support group for appendix cancer and pseudomyxoma peritonei, and we're honored to continue the work of Gabriella Graham, our founder. All of us on the board are here because of her work. I literally would not be here if it weren't for Gabriella. So we're honored to continue paying it forward. Just some disclaimers as we begin the discussion. We are here for patient support and information. We are not licensed physicians. And even though we do have a licensed physician on today, we are not giving medical advice. We'll give you some things to consider as you get your own licensed medical team, but we do not provide medical advice. Please keep that in mind. We have checked the presentation. You're not going to see graphic images or scary information today. So we know you're going to enjoy the presentation, no fear there. But please do realize by participating in these forums, your identity and health condition may be shared with the public. The physician calls are particularly popular, so we will be recording this and sharing it later. So please keep that in mind. You're welcome to change your name. You're welcome to turn off your video. You don't have to share that information, but it can be technically difficult. So keep that in mind. And then finally, you do share permission for your likeness to be shared with the general public, as again, we are recording this. ground rules real quick. We are here for you. This show will go for an hour and a half today. Do not feel obligated to stay. We're here to support you and help you on this journey. You do not need one more obligation. So thanks for being here. But if you need to go and enjoy life and take care of business, go do that, please. We do encourage the use of the chat function. Feel free to leave encouraging words there, your contact information. If you are resonating with someone in particular, feel free to do that. And then we will do a hard stop today. We will stop hard after 90 minutes. That's how we do our physician presentations. And then finally, we encourage you to stay connected throughout the week. You can see us at pmppals.net, on Facebook at the PMP Pals Network, and on Instagram at PMP_Pals. And with that, I'm going to thank and welcome my good friend, Dr. Hisham Abdel Mageed from the National Cancer Institute in Cairo, Egypt, for being here today. How are you?
I'm good. Thank you for inviting me.
Yeah, thank you for being here. Now, I think it's 6 o'clock there right now, 6 p.m.
Yeah, exactly, 6 p.m.
We appreciate you giving up your Saturday evening with us. Thank you for being here.
It's my pleasure.
Now, I had the pleasure of meeting you for the first time in Paris a few years ago when we had the annual symposium. And
yeah, Soji.
Fantastic Soji. And then we got the chance to have some fun together too. So I know you'll probably share that story as well. Yeah. We got to see you two in concert in Paris together. So a lifetime memory, right? Look at Seal. She's like, yeah, that's how I felt too, right? Just to find out they were playing, and so made sense to go while we were there. Good. Well, good. Well, again, thank you for being here. We are excited to see your presentation, and thank you for sharing your experience and knowledge with us.
My pleasure. Pleasure is mine. Hi, everyone. So today, this is not going to be any graphic presentation. It's going to be sort of a light-hearted presentation. My name is Dr. Hisham Abdel Mageed. I'm a surgical oncologist at the National Cancer Institute in Cairo, Egypt. As Chris said, we met in 2018, I think, in attending Soji in France. And I was also lucky to sit with many of you on the same table. And as Chris said, we attended this concert together. It was a memorable day. And today I will be talking about hyperthermic chemotherapy in Egypt. And an interesting piece of information which I found is that the first use of heat against cancer may go back to around 2600 BC, recorded at the Edwin Smith Papyrus, which is currently at the New York Academy of Medicine Library in the historical collection. It may have been mentioning possible use of heat against breast cancer in one of the cases. And if you fast forward a few thousand years, in 2008 or 9, I think 2009, the first case of hyperthermic chemotherapy was operated in the National Cancer Institute, which lies in Cairo. You can see the building looking at the Nile. It was done in 2008. It was a recurrent colon cancer case, and it was performed by Dr. Wahid Yosri from Egypt and Dr. Dick Verval from Holland. As you can see here, this is the first Hypec machine we had in Egypt. There was a closed Hypec machine. And since then, Hypec has, we had many Hypec procedures performed. Approximate number of cases ranges around 500 cases. At least 7 hospitals now perform Hypec regularly. Primaries treated are the same as worldwide: ovarian cancer, colorectal cancer, pseudomyxoma peritonei, appendiceal cancer, and gastric cancer. And recently there has been a rise of indications, including many miscellaneous tumors like uterine cancer, hepatocellular carcinoma, and others. Since then, we had many Hypec workshops where we have international speakers joining us in Egypt to show us the latest in Hypec technology. For example, we had Dr. Marcello De Rocco from Italy in 2016 in a Hypec workshop, and of course, Dr. Paul Sugar-Baker. I was lucky to meet him in a lecture in 2016, and I was lucky to take him to the pyramids and show him around. 2 years later, Dr. Paul Sugarbaker joined us again in a workshop, and we were lucky to see him perform intraoperatively and to participate with him in the OR. This is a picture which I cherish of me working with him. And I also was lucky to show him around. You can see Dr. Sugarbaker with the bent pyramid and inside the red pyramid here on the left, and enjoying some local Egyptian food. And last year we had another workshop where we had Dr. Beata Rao from Germany, Dr. Marcello again, Dr. Kurt van der Spieten from Belgium. So we are gaining, I mean, Hypec is being performed more and more, and every year we get new international speakers to give us their experience. And in 2019, we invited Dr. Olivier Blehen from France. My personal experience with Hypec started in 2012 when I did my master's thesis about Hypec. And recently I just published a paper in the European Journal of Surgical Oncology. So we are slowly starting to increase our publications regarding this topic. And there are too many variables in the topic of intraperitoneal chemotherapy regarding the indications and different surgical techniques and different chemotherapy regimens and different delivery methods, different timings of cytoreductive surgery and Hypec, and so many different variables. So it's very difficult to find any, let's say, standard of care. So, and they are currently trying to solve this at SOGI. So I'm currently working on a publication discussing this topic, and I'll also give you a brief history about where the National Cancer Institute, where I work. The National Cancer Institute made international headlines in 2019 when a bomb accidentally blew up in front of it. So like there was a terror attack planned elsewhere, but something went wrong and the bomb, the guy detonated in front of the building, but luckily it happened at midnight, so no one was injured. And if it would have happened in the morning, it would have been a disaster. Of course, it was still a disaster, but not many people were injured. We lost 2 people, but imagine if it happened in the morning, how many people we would have lost. So ironically, when this happened, this gained us a lot of international attention, local and international, which an example for the damage, like this is, for example, my head of department's office, and you can see Dr. Sugarbaker when he visited, he was sitting on this desk, and you can see in the rest of the pictures the damage which was inflicted to this room. So after this bomb, a lot of media attention led to finally a lot of renovations a lot of donations poured in, and it sort of turned into a national issue. So they started finally renovating the building. You can see it here, starting to renovate it. And this is how it looks after the renovation. And this is how it looks now. Like it looks totally different from, looks new, and inside as well. And even in the OR, everything has been renovated, and which will definitely be doing more Hypec in the future. They even did some rebranding and got a new logo. Can you hear me?
We can.
Yes.
It looks beautiful.
Yes. And on the long run, there's also, they started a new National Cancer Institute, but it's still under construction. It may take years because it's supposed to be very large, so it needs lots of funding, and they're working on it. I expect maybe we might see it in 10 years or less. You can also check out this website to see the progress. Thank you. That's it.
Absolutely beautiful.
That was shorter than anticipated. I planned, I thought it would take more time.
Oh, no worries. I mean, this is great because patients always love to have time to ask about their particular cases. So if we have time to go through that today and you offer your thoughts and opinions, that'd be incredibly helpful for people too. But this is a beautiful presentation. I mean, such a beautiful country, rich with culture. I mean, I think the pals, we look forward to a trip to Cairo sometime to visit you as well. So thank you for sharing this. You know, the other thing that resonated with me, I'm sorry about the bomb incident, but I think one of the things we learn on our cancer journey too, right, is even in the midst of terrible things happening, right, there is still beauty in what comes from it many times. And so this is a devastating diagnosis for us as patients. We lose a lot of control and we have to deal with that suddenly. So it's a very difficult thing emotionally. But we also learn a lot of beautiful things on the journey too, right? We get the chance to meet great people like you and realize that you're humans too, and that you guys really do care about us to a great degree. So some of the beautiful things that come with this journey. I will remind folks, I am monitoring the email zoom@pmppals.net. So you're welcome to send questions there if you'd like us to ask those questions. And we'll take time to go around the table and have people check in with Dr. Mageed. But, Dr. Mageed, a couple questions that came to mind for me. When you got to work with Paul Sugarbaker in the operating room, what was that like?
It was very interesting to see him perform because, you keep reading many publications and but when you see the operation in real life, like there are things which don't make it to the publications. I mean, the small things which are different, or like some technical tips which he does, technical variants, and the dedication. Like, for example, everyone was keen to like finish the operation and maybe go to, because we are in a workshop, but he was like, forget the workshop. Like, I'm here until the patient, I'll do the patient from start to finish, and I'm here until I finish. You understand what I mean? Like, it's
Absolutely. Yes, I understand completely. I mean, for those who don't understand, the dedication of the surgical oncologist is astounding, really. This is them standing for 10 to 15 hours, sometimes 20 hours over the patient, carefully finding every bit of disease and carefully removing it so as to not cause injury, but to get every last bit out. And so, yeah, the dedication is truly amazing. Dr. Mageed, I have a funny picture I share from time to time. I'm not going to share it today, but the night before I had my surgery, the nurse came in and she marked 4 spots for ostomies in case I needed it. And I said, hey, can I write a message for Armando Sardi, Dr. Armando Sardi back in Baltimore? And she said, sure. And I wrote, get it all out on my stomach, which obviously is a nod to the fact that the cytoreduction, the removal of the tumors, is a critical part of this surgery. And so the skill of the surgeon really makes a difference. Do you have any stories of teachings that Dr. Sugarbaker taught you? I know I've seen him talk. I mean, I saw him talk 15 years ago in Aspen at one of the earliest symposiums that UPMC put on. And it just his experience and knowledge was just so amazing. Just, you could hear him talk about the subtle variations in the disease. And if he finds disease in a certain part of the abdomen, he always checks another part of the abdomen because he expects to find disease. Are there any memorable lessons that he taught you?
For me, every time he comes to Egypt, I think he came at least 3 times. Every time he comes, I try to stick to him. I mean, even when I try to get him even from the airport, so like spend the most time with him as much as I can. And it's not just surgery. I mean, the methodology, the way of thinking, always trying, the passion, still trying to find ways to, I mean, after all these years, and he's still always working, trying to work out ways to improve this treatment. I mean, it doesn't end.
Truly, truly. And as you talk about the variability of Hypec nowadays, right? I think this shows that. I mean, there sounds like there's lots of opportunity to understand the nuances, the chemotherapeutic agents selected, the times that we use for perfusion. Sounds like there's opportunities for standardizing some of that.
I think there's still a lot of work to go regarding the standardization, because there's too much research going on. So, and they're all valid points. I mean, there are so many variables, and you still cannot point out to one variable and say this is the one which we prefer, because they all seem valid. But if you want to increase the number of Hypecs performed and to make it reach mainstream treatment, to become mainstream, I mean, you have to find at least one variant and try to standardize it. So you understand what I mean? I mean, you need to focus on one variant to make it the standard of care. So to make it more popular, because if someone decides to let's explore this Hypec treatment and see if I can offer it to my patients, and with all these variables, it will be very difficult to choose which one to offer. So
yes, that does make sense. And the way I interpret what Dr. Mageed is saying is that as we analyze different nuances in how we do Hypec, how they do Hypec, right? If we're changing all these variables in the surgery, then it's hard to compare the results.
yeah, exactly.
Oncologists are, they're not just amazing surgeons, but they also have to have a strong grasp of statistics, as well as many other things too. These are very, definitely the smartest people I've ever known. And so understanding all these things, they're going to analyze every aspect. And so that would be something they would discuss and debate, right? Is it really better to do more time or to use this chemotherapy? And so these are the details that they really pore over and focus on as they're seeking the best care possible for us, for sure. Well,
Yeah, Dr. Mageed, I think your presentation really shows what a small world it is. And so how important it is to make available, Hypec and CRS for patients, particularly with this rare disease. Where do most of your patients come from?
All over Egypt, because we are
Okay.
the biggest tertiary cancer center. So like we get the cases which no one else maybe accepts. So we are the biggest referral center, I mean the center.
Yeah, no, that's great that they're finding you. Is it more word of mouth, or is there some sort of centralized system that either medical oncologists or other physicians know if a patient has this, they know to send them to you?
They sort of know that, like most practitioners know that when they meet a case, a cancer case, they basically refer it to the National Cancer Institute.
No,
Unless, of course, they can handle it. But I mean, we get usually most of the cases which no one else wants. I mean, the complicated cases, or the sort of like you can compare us to maybe MD Anderson, or like the big centers in the States or anywhere.
And so in Egypt, do you find other surgeons in the country that want to work on appendix cancer? What's coming to mind for me is in the US, we understand that the specialists need to operate on patients, right? The literature tells us that the experience of the surgical oncologist and the experience of the hospital are significant in the outcomes of the procedure. But we still today, even with the knowledge we have about the disease, right, we still have local surgeons who want to conduct surgery on patients. And so this is a challenge that we often go through. Is it the same situation in Cairo, in Egypt, or like do doctors uniformly refer appendix cancer patients to you?
I think when it first started, as I said, it was just one person. Then maybe the number rise to 5. I think, of course, the number is rising now, but it's still not that popular. Not that popular. I mean, not that common. So it is still limited to mainly the surgeons who work at the National Cancer Institute, but people are catching up with all the workshops being held and more machines are being bought. But I think I would still say the surgeons of the National Cancer Institute are the most people performing Hypec.
Well, good. Well, I do see an interesting set of questions here in the chat. I see that's just to me. So what is the oldest patient that you've operated on, Dr. Mageed?
You're talking Hypec or?
Yes, Hypec.
No, I think the age the age of patients undergoing procedures here is different from like when I traveled abroad, I saw them performing on very old patients, which we wouldn't handle here because it's not just about the surgery, the whole facilities and the ICU and even the type of patient. Because most of different type of patient. Because I'll give you an example. For example, Dr. Sugar Baker, when we had him perform a surgery, we told him all the information 1 day before. So he was informed that the patient was 60 years old and she had pseudomyxoma, and he was like, okay. After he got all the information, he said it's okay. The type of patient is different. I mean, every country has its own criteria. I mean, maybe in the States, people have more obesity, whatever. I mean, there are always different criteria in the patient. Here we have the different. Most of the people with advanced cancer and stuff like that are. I mean, we wouldn't go to operate on a 70-year-old unless if he's or he or she is in a good general condition. So
Dr. Mageed is explaining that, right? There can be specific criteria, but each of us is an individual case is how I would interpret this, right? We have definitely been in contact with patients in their 70s who have had Hypec and done very well. We've had patients come on the Zoom call, as a matter of fact, who are in their 80s who had Hypec in their 70s. So we are definitely familiar with patients, but each of our cases is unique and individual. And regardless of our age, if there's a great burden of disease, then the surgical oncologists, they don't want to do more harm than good. So, right, that's often something they consider, the burden of disease. But each of us deserves a chance for care. And, we recommend that you seek many opinions and get educated. I learned something from every call with the physicians and even with the patients every week too. I learned something new. So we encourage that education and getting multiple opinions as you're seeking your care. But never forget, each case is individual. And I know, Dr. Mageed, that it seems the physicians want to see their patients too, because that makes a real difference in just understanding how they're going to do after surgery as well. So what has your experience been with signet cell in the disease, Dr. Mageed? Do you recommend chemotherapy first for your signet cell patients?
This is a bit of a generic question. I mean, you cannot. We would recommend chemotherapy, but I mean, I cannot just answer. This is not enough information to give you a direct answer. I mean, you have to look at every patient. You have to examine every individual patient and see. I mean, there are too many criteria which I have to judge before making the opinion, giving my opinion.
Got it.
What is the average length of stay in the hospital after you've performed CRS and Hypec?
Probably 1 week. First few days in the ICU, but after 1 week, we of course would know any unfortunate events. After 1 week, you should be at home.
I'm reading through the questions too, trying to see what's the next question to ask as well. So here's a good question. Is at the NCI in Egypt, are you considering any new future research or techniques in the treatment of appendix cancer?
We had Hypec performed last year as part of a workshop, but I don't think it's still commercially available. I mean, we for that workshop they had special instruments. They had them with the surgeon performing the pipette had got them with him, but we don't have them now. But maybe in the future we can see it.
Good, good. And so who came and did the pipette procedure?
There was a Saudi surgeon, Dr. Mohammed Aliami. He learned it in, I think he was working in France with Dr. Olivier Glehem. I think he's the one marketing Pipec in the Middle East these days. I think he works with Dr. Delia Cortez, which was with you last month.
Correct. Yep. That's great. And so, and what are the barriers, right? What are the difficulties for doctors like you to access, get trained, and use new techniques like PIPAC? What would make it easier for you to learn a new technique and bring that into the hospital for patients?
Of course, first of all, maybe financial issues, financing, travel, and the conferences, and to attend conferences or to go for training and stuff like that. Maybe some bureaucracy. But I think it's the first barrier is financial factors, and then trying to implement something new. You have to implement it throughout the whole system, and you're limited also by not just your financial factors, like financial factors of the hospital and the implementation with nurses and the ICU, and it's like the whole system. So if you cannot just you cannot just modify one part, which is like the surgeon. So give him teach him the new technique, but then put him back in the old system. So he will first struggle to try to implement this new technique.
Right. And so I think Dr. Mageed is pointing out, right, this is a team effort. And it's not just Dr. Mageed and his staff, right? There's also the hospital. And I think through these calls, we've learned that each hospital is unique in how they operate, right? Having the right time in the OR necessary, right? There's competition for limited resources amongst the physicians. Just having the appropriate equipment and then having the proper procedures for cleaning that equipment or whatever those procedures may be. But it's a whole team. I was honored to work for an oncology company for 10 years and be in a lot of the best oncology centers in the US. And it's an amazing thing to see all the inner workings and the number of people that are working to help get us back to health. And starting something new is complicated. There's lots of people to train, lots of people to educate and influence too. Good. Dr. Mageed, do you have any favorite cases that you remember? Any patients who you're very proud of the outcomes that have happened for them?
I think any pseudomyxoma case, because the patients, when they first come here, especially that most of the patients are here, we have here are illiterate, low income population. So when they come to you, they don't expect you to have a treatment for their case, because you know how pseudomyxoma cases can keep progressing without actually harming the patient. They will not kill the patient, but so the patient will come to you with a huge abdomen, not expecting you to be able to treat him. But then after the operation, I like to ask the patient if he notices any difference in his before and after the operation, and of course they do.
It's good.
Yeah, Chris, I think that comment just shows how caring all of our surgeons are in wanting the best outcome for the patients. So we thank you, Dr. Mageed, for that. The question in the chat, how many cases of recurrence do you see in Egypt?
You mean recurrence after Hypec?
Yes,
doing
yes. Do
Hypec
you
twice?
see very many?
I think we've had a few cases. There are a few cases of recurrent Hypec of patients undergoing multiple Hypecs, but maybe maximum 2 Hypecs. But the exact number I'm not sure of, but probably not more than 20 or something, but I'm just guessing here.
And I'm curious, how many patients end up going through the Hypec program per year at your hospital?
So as I said, we almost performed 500 cases in the last 10 years. I would guess, of course, there are ups and downs because sometimes we don't have the kits, and maybe this year we have the pandemic, so you cannot go for the major operations. You become very selective during the pandemic. So I would guess maybe 50 cases per year in our hospital, and plus a few cases here and there in other hospitals. But it's slowly, the numbers will increase, but maybe after the pandemic.
Well, and I'm thinking, Adele, maybe we open the floor to questions with some of the patients.
Sure.
Yeah.
And I think Charmaine has a question.
Yeah, I never have been able to see that raised hand button, so I'm going to do the clapping hand instead. It might be my technology limitations, but I wanted to ask about patient support in other countries. We consider ourselves to be a worldwide organization, and we know that in other countries there are some local efforts. We've talked to individuals in France and China, for example, who have started groups similar to PALS. But what would you suggest as how our group could reach patients? I know there's always a language issue, but I know a lot of people do speak English all around the world. What would you suggest to really promote patient support in places like your country where maybe a group like this doesn't exist?
I think maybe we can start by suggesting, I don't think you have to change anything because we don't have enough patients for me to suggest to you to start maybe an Arabic version of the website or something. But what I would do is refer patients who I would think benefit from your service, refer them to you or to similar groups elsewhere. But maybe when the number of cases and procedures starts rising enough, we can maybe consider doing a local version of this service.
Well, we would certainly love to have any of the surgeons, yourself and others you work with, refer patients who could benefit from support in whatever way, especially if they have some proficiency in English or if they're able to use a translation service from Google or whatever on their computer. So just please keep us in mind, and we're here to help patients not just in the United States or Great Britain, but really around the world. And we have quite a few patients pop up from surprising areas. So just wanted to let you know that we're here regardless of what country, and we'll do our best to try to help people with questions from the patient perspective.
So Dr. Mageed,
are you connected with similar group? I mean, how many other groups are you aware of who do something similar?
Well, I would say personally, I know that, like I said, I've met patient representatives in France. I know there's an active group, and we met a young woman from China a few years ago at Soji in Washington, D.C., whose mother was the patient, and the daughter was organizing a group in China. But throughout other places around the world, it really just seems like individuals find us. There are not organized groups in many countries, whether it's because, like you said, the number of patients is just too low to support a separate group. And they find out about us somehow. We sometimes don't even really know how, but I just wanted to use this opportunity to promote the idea that, you know, we are here to serve others. And if you have patients who could benefit, please pass on our name, and we'd love to see them one day.
Sure, will do.
Orna, I saw you raising your hand, Orna. Did you want to say something?
No, it's not so important, just to add, because I'm very proud of it. There is in the Netherlands now, we are really working very hard and developing a real program in Dutch, because some people have difficulties with understanding English, because we refer to the PMP pals. It's on our list, but not everybody can manage with the English. So we have now started our own websites with attached to a bigger organization. So it's really a big project, let's say, with a lot of information and aids and how do you call it? I forgot. Patient advocacy, etc., etc. So, but I mean, it's Dutch, so I don't think they need it in Egypt. They can better go to the English. But I just wanted to share it, because it's really something which is growing now very quickly.
Well, that's great. Yeah. And it shows how even in a smaller country, how that kind of organization can grow to meet the local needs. So that's
yeah.
Well, that's fantastic. And it might be a good time for us to do a quick commercial break and show you some of the ways that we can support you on an ongoing basis. Like I said, we're monitoring the Zoom at pmppals.net email today and throughout the week. So you're welcome to send questions or comments for the physicians, suggestions for programs you'd like to see in the future. So we hope we'll continue to see you on the Hope Zoom call. And then one of our oldest programs, the Bare Bottom Bears program, we'd encourage you to order a bear as you head for Hypec or start chemotherapy, to be with you and remind you that you're not alone while fighting a rare cancer. You can always reach us at info@pmppals.net throughout the week. Adele will quickly make sure your information or your question gets answered by the right people. If you have more technical questions or perhaps questions about medical jargon, Arthur Rettig is a retired pediatric surgeon and also a PMP patient. So he's got great insight and advice and can demystify some of the questions you might have about the disease. Our most popular program is the Get Well Cards program. I strongly encourage you to request your Get Well Cards. And while you're under care, you'll receive a box of cards, which is a wave of love from patients all around the world who have been involved with PMP Pals for the long time we've been running now. And so again, it's a very moving experience to get those cards. We definitely encourage it. And then the starter kits. If you send an email to starterkits@pmppals.net, we'll happily send you a bag that contains wet wipes, disinfectant and chapstick, a pamphlet that's got some useful information, and a notebook for when you go for your consults, so you've got something to write down questions. Finally, I will remind folks that we are a completely donations-run organization. The leadership team, we don't make money at this at all. This costs each of us money, and we're happy to do that and pay it forward. But if you would be so kind as to consider going to our website, you can make a donation through PayPal to the organization to support these programs and continue making sure patients are supported as they're diagnosed and treated. And you can also sign us up on smile.amazon.com and register PMP Pals as the organization you support, and we'll get a portion of all of your purchases there. And then again, just finally online, as a reminder, pmppals.net, and Facebook, the PMP Pals Network, and then Instagram, PMP_Pals. So we're happy to stay in touch with each of you throughout the week and make sure you're supported. Dr. Mageed, one of the things we find is there's a year of treatment that might involve chemotherapy depending on your pathology. we recommend that all patients consider Hypec. This is probably something that's going to be in our future. But there's an emotional component that goes on for years after this big surgery. And so we're happy to support your patients, and no matter where they are. And Orna, we thank you for your work that you're doing too, to make sure patients in the Netherlands are supported. But yeah, there's a couple of journeys that happen on different levels. So happy to support your patients and glad you're here.
I will definitely be referring patients to your group.
I appreciate that. Paul, did you have a question?
Yeah, I got a couple questions. Are there any special procedures or treatments that are being used at your hospital in Egypt that may or may not be used in, say, the United States? That's the first question. And the second question is your hospital a public or private hospital? And we all know that the procedures that we go through are very expensive. Your patients, are they covered by insurance, or is it government subsidized? How does that work in Egypt?
Well, first of all, we are a university hospital, which is sort of a public hospital. So patients here, they get the treatment almost for free. This procedure, when performed in the private sector, it may cost up to maybe 100 or 200,000 pounds. That would translate to, let me translate that to dollars. So 120,000 pounds is equal to $8,000, which is still, I mean, if you pay for the procedure in the States, it will definitely cost a lot more.
It beats the alternatives.
Yeah. Because I remember, for example, a patient who was asking, who got a consultation to go perform to get a Hypec in France, and she was asked for €500,000. So compare that to $8,000, that's nothing.
So the question about procedures
was the first question?
So the question about procedures and treatments in Cairo versus what's here in the United States, anything progressive?
No, I think it's more or less the same procedures, because we do follow the guidelines. I mean, we don't necessarily follow the American guidelines, but I mean, we at the end of the day, medicine, I think, is the same. We're not doing something which is not maybe allowed in the States or something. It's of course, it's a different system. I mean, for example, we as surgical oncologists here in Egypt, we do every part of surgical oncology. While if you go in other countries, you will not. Head and neck surgery will be performed by some specialist, and the GIT, the gastrointestinal surgery, will be performed by another surgeon. But here we can do it. We do every procedure. We are starting to specialize, so this is maybe the main difference, that we're not that specialized yet, which is a benefit for us. Like, we have more access as surgeons. Like in the States, maybe surgeons will be more specialized in one part, but here in the States, maybe in the 70s, for example, they were like us, but then they started specializing. Here we started specializing maybe in the last 10 years. So this is the main difference. But the procedures performed, the treatments given are the same.
So I take that to mean one day you could be performing surgery for a breast cancer patient, and the next day doing Hypec, and maybe the next day doing a pancreatic cancer patient treatment or something. That's a lot. That's challenging.
Yeah. But we are on. I mean, the future will be more specialized.
Sure. Mm-hmm.
We're on it.
And so I have another question here that I'm going to ask. And I know we chatted about this before we started the program too, but the question is, how is Egypt doing with the pandemic? How is distribution of the vaccine? And are you seeing an increasing number of variants in that region of the world with COVID?
I think we're slowly regaining the normal rhythm, as I said, and we're starting, the vaccination started last month. And I just heard that they're getting more different types of vaccines. So we started with a Chinese variant of the vaccine, but I think in the near future they will be getting more different types into the country, and of course they're starting with the doctors and the elderly. I think the same as everywhere, like they start with the most vulnerable people to give them priority to get the vaccine, and then allowing it for the rest of the population. I think generally, if you go out into the street, you're starting to, of course, there were times when the streets were empty and everyone was wearing a mask. Now it's getting more and more back to normal. I think so. People are still wearing masks, but not all of them. Streets are slowly getting crowded again. You start witnessing more traffic in the streets. Like the usual old Cairo traffic is slowly coming back. So I think these are all like indicators that we're slowly going back to normal. But you have, and it's very easy to forget I mean, when you go out in the streets and it looks normal, it's very easy to just think to forget about the whole COVID situation and start taking less precautions. But we should, I think we should stick to the precautions maybe a few more months until the pandemic ends.
We appreciate that perspective. Obviously, you're incredibly intelligent man, so that's good to hear that perspective from you.
I think today I get the prize for being the person diagnosed the earliest. I know there are others who were diagnosed earlier than me and are still here, but I was diagnosed 23 years ago. But the interesting thing to me still is, and Dr. Mageed, I'm in Austin, Texas. The city is about 1 million. It's not a small city. But still, I have never met another person who has PMP or appendix cancer outside of the support group environment. I've met, of course, lots of people through this group, but if I didn't have this group and just were going through my daily life, I don't have friends, family, workers, neighbors, nobody that I've ever known who has been diagnosed with this. So it is kind of interesting to me that, like Dan Henry's experience in a small town in New Jersey where he lives, he knows 2 or 3 other people, but some of us know absolutely no one, like I said, other than through this support group. So we may learn later on there are geographic pockets, or it may be like you just said, Dr. Mageed, that the more people who survive and you encounter them in your life activities, you have an opportunity to learn. So I think areas where there is good treatment, you're going to see just naturally more people know about it and have had the proper diagnosis and treatment. And then areas where there isn't that kind of treatment available, you just never hear about it. And Austin's not an area where surgery is performed up until recently. We do have a specialist now who's performing, who was on our program a few months ago. So it is an interesting distribution of the PMP and appendix cancer population.
Yeah.
Also, too, Chris, correct me if I'm incorrect. Chris and I attended the Global Genes back in 2018. It was a conference. And one of the things that they were working on statistically was better documentation of appendiceal cancer, PMP, versus putting only colon cancer, which would help identify additional patients. You know, so they can get collectively maybe better statistics with regards to this disease. Chris, am I incorrect or correct on this?
Whoops, just realized I muted. No, I think you're absolutely right. I think they are trying to aggregate patients. And so this was one of the keys that the Global Genes Conference, taught us, right? As we can pull together that information and have a database, then it's going to be helpful for physicians to start to understand more about what might be causing our disease. we know too, extensive genomic analysis has been done in our disease as well. And it's interesting how different it is from colon cancer. It doesn't have the mutations that are the same as colon cancer to a large degree. But we are unique in that way. And there doesn't seem to be many mutations really. The only unique thing is the GNAS mutation, and there's no medicine that can act on that right now. So anyways, lots of opportunity for learning. Adele, perhaps we should check in with Linda and Brian. Looks like they have a question.
Yes.
I want to thank you for all the efforts that you've done putting this together. Linda and I, of course, have been working through this interesting cancer. My question is about diagnosis. It seemed to be a very difficult disease to diagnose correctly. I was misdiagnosed, for example, and I think I had good surgeons, but they knew nothing. They opened me up and they noticed what it was. So they virtually washed me out and put me back on my feet. And 2 years later, I had an operation down at MD Anderson with Hipec, and I've been healthy ever since. So it's just interesting why it was not diagnosed the first time correctly. Does anybody show any advancements in diagnosis of PMP?
As you said, it's not a common disease. So even doctors are not, unless if you work maybe at MD Anderson or similar big oncology centers where you see these cases commonly, there is of course a chance of misdiagnosis or delay in diagnosis.
Yep.
I think the message is the most important thing is like once you suspect it, I think it's best to directly refer to a well-experienced center and not waste time trying to investigate. I mean, send it to someone send the patient to someone used to handling this disease.
I was diagnosed with a CAT scan. Is there any MRI diagnosis that's coming online?
There are different methods of diagnosis. They're all valid. I mean, it's not about the technique of diagnosis. I mean, in some cases you can get diagnosed during surgery. So it's about you can use CTs, you can use MRI, maybe a biopsy, whichever the method of diagnosis. The important message is like to refer to a big center with more experience in diagnosis and management of this disease. So the exact method of diagnosis is not the issue. I mean, you can diagnose it with a CT, an MRI, maybe an ultrasound, whichever imaging you use. But the important thing is to manage correctly.
Just gotta know what you're looking at. With a specialist.
Yeah.
Well, and Brian, it's not uncommon. You know, I think with the advancements in medicine, I think more people are being diagnosed earlier with imaging technology improving. And so I do think patients are getting discovered earlier, and we're always doing our best to make sure that they get referred to care. We're certainly putting our messaging out there to say, hey, find a specialist, because that's going to give you the best chance of outcomes for sure.
Yes.
Well, we're glad you're here. Thanks for being here and being part of this. Good to see you all.
Good to
Kelly,
see you.
did you have a comment?
Oh, I just wanted to follow on to Brian's statements. I really like how you characterize this as an interesting cancer, because I've never heard it called interesting before. And the second thing is, we as patients are often told we need to be our own best advocate. And on the misdiagnosis front, when you go in to a specialist, any kind of specialist, you have potentially colon cancer or ovarian cancer. It never occurred to me to say, oh, gee, I need to seek out an appendiceal cancer specialist to get a second opinion, because you don't know anything about it at that point, potentially. And so I think it's been very helpful that more people in the medical community are becoming aware of appendiceal cancer, because in my case, I was suspected of having ovarian or endometrial cancer. And luckily, when they went in to do my hysterectomy, they stopped when they saw the appendix was unusual and called in a couple other doctors who were familiar with appendiceal cancer and said, you know, stop right there. Don't take out the appendix. Don't touch it till she needs to go see this other specialist. And, you know, unless you have a doctor who has been around the block and maybe is more aware of it, misdiagnosis, I think, continues to happen at too high of a rate. That's all I had to say.
Kelly, it's always good to see you. Thank you for being here. I love seeing your face. So, so thanks for being here. Hope you're doing good. And then we've got just a couple minutes left. And Elaine, I see you've got your hand raised. Did you want to go ahead and ask your question?
Yeah, I have a question. I have 2 primary cancers, appendix and colon. And I was wondering if you've run across that where you are. And even though the survival rate, the overall survival rate is pretty good with the appendix, does the colon cancer end up still shortening the overall survival for people?
Well, hopefully not, but to properly answer this question, I would need more details. But generally, I mean, depending on how much of every type of cancer there was, I mean, to truly judge, you have to see which. You said you have 2 primaries, but to what extent is each one of those? So, but hopefully, I don't think hopefully it will not affect, but to give a medical answer, I need more information.
And Elaine, at least for me, in my experience,
Can you hear me?
you know, if my mom was in your situation, mom's on the call. She was earlier. I'm not sure if she's still here, but yes, hey mom, I see you there. Thanks for being here. But if mom was in your situation, I would say Hypec is your best chance, right? Chemotherapy and Hypec, you know, together in combination would give the best chance at great outcomes. And so, yeah.
Do you guys do your Hypecs laparoscopically in Egypt or no?
Yeah, some of them, yes, but mostly open. I mean, the usual Hypec, whether open or closed. But there was some laparoscopic Hypec, but
Very good.
I mean, for practicality, it's better to, because of course the procedure is still, it's 10 years old here, but it's still not that common and popular. So it's better to stick to the usual, especially that most of the cases which require Hypec are advanced. And I mean, to find cases which would go laparoscopically with not that many cases, but they were performed.
Thank you. Appreciate that very much. And all of your input today. You've been very informative to us, and we're lucky to have you here.
Well, Elaine, that's a perfect segue. If I could ask the group to give their thanks to Dr. Mageed for being here, sharing his expertise and reminding us how much our surgical oncologists care about us. We really appreciate having you here. Good.
Thank you all. Thank you.
Well, thank you everybody for another wonderful episode of the PMP Pals Hope Zoom call. We're grateful for each of you. Glad to be here to help. We hope we hear from you throughout the week at pmppals.net and the various emails I mentioned earlier. And we hope you remember PMP Pals has hope for you. Thanks, everybody. Make it a great week.
Yes, thanks, everybody.
Bye-bye.
Have a great week.
Thank you. Bye-bye.
Dr.
you, Dr.
Mageed.
Mageed.